So, dear colleagues, dear all, I had the um, task to present you the clinical practice of GMA in IBD and particularly in UC. So I decided just to go throughout a patient here in Rennes, in France, who was a woman, 40 years old. She was a teacher without smoking, and she was diagnosed with a UC pancolitis in 2007, and she began classically mesalazine. She doesn't respond, so she starts steroids and cismacaptopurin because of an intolerance to azathioprine. And she had a good way of life at this time from 2008 2014. However, in 2014 she relapsed, and we start adalimumab, but she was a primary non-responder to adalimumab, so we move quickly to infliximab in combination with methotrexate. And unfortunately, she was also a primary non-responder to infliximab, and just vedolizumab arrived in France, so we start vedolizumab. But one more time, she had a primary non-response to vedolizumab, and we had a unified trial, and we put the patient in this trial, but unless the open arm, she doesn't have any response to estaquimab too. So we start at this time and also in 2015 to discuss surgery with the patient, but she declined swine. She declined a second time the surgery, and just for a compassionate use, the tofacitinib arrived in France, so we start tofacitinib in 2017, and she had a partial response, but she still had bloody stools with weekly bloody stool, night bloody stool. So we discuss again surgery, but she declined the surgery. And all of this time, she was on the steroids with some low dose and sometimes high dose of steroids since 2014. So, what could you propose to this patient? So, who she really don't want any surgery. She met the surgeon, and we doesn't try, and we just don't convince the patients to go to the surgery. So this was the scope procedure at the time of the patient on tofacitinib, and we just had GMA in the university hospital. So we proposed the patient to start GMA, and so the question is how to tell to the patient how much response we can expect to have with the GMA, and as you know, we had first study from Japan with a quite high rate of response and remission, about 60 to 70% of patients who had a response with GMA. And as Eugenie told, we had recent randomized control trial, and so this is the last one. This was Eugenie, who was at the operational view of this trial. And so this was a trial where patients were put on steroids, and they were on remission on steroids, and they start GMA. So it was one weekly sessions of GMA, and with a tapering dose of steroids after two sessions of GMA. And the primary endpoint was at week 12 with clinical and endoscopic assessments. However, as you can see, this trial was negative because in blue bar, you have the Adacolumn response. You had 20% of patients with steroid-free remission and 13% of patients with endoscopic remission in this trial, but it was not superior to the use of prednisolone alone. The only secondary endpoint we had in this trial is that the time to relapse were decrease in the patients treated with Adacolumn. So just a negative trial on an Adacolumn. And we had also this American trial published in 2008, and patients were randomized to receive a sham procedure or the GMA. And as you can see, whatever the endpoint was, clinical remission, clinical response, endoscopic remission, and endoscopic response, we don't have any difference between the sham procedure and the Adacolumn procedure. So you can think that finally, why to use Adacolumn with these two negative randomized control trial? However, you had to read this trial. Just to put this slide to in the American trial, we had just perhaps a subgroup analysis of patients who are erosion or ulceration at the histopathology, and these patients had a better response. When they were treated with GMA. So perhaps we had some subgroup of patients who had better response to GMA, but it was just subgroup analysis. And when you look at the procedure of this trial, and both trial had some issue, and as you can see on the left of the slide, about 100 patients were randomized in the GMA procedure and 50 patients in the sham procedure. However, at the end of the trial, you see that only half of patients were still treated with Adacolumn and less than 1 to 5 patients in the placebo group. So you had more than 20% of loss of follow-up in this trial, and you cannot conclude in a trial where you have so much loss of follow-up. Also in the Spanish trials, this was the same. 240 patients were planned to be enrolled in this trial. However, due to the lack of recruitment, the trial stopped early, and perhaps Jenny could discuss this point at the discussion sessions, but we don't have a power study to conclude if there is a superiority of Adacolumn as compared to a sham procedure. And one more time, when you look at the patients assessed at 12 and 40 and 24 weeks, you see that almost 50 to 70% of patients were lost of follow-up in this trial. So it is difficult to conclude in these two randomized control trial whether or not Adacolumn is effective or not, because we don't have the power to take this conclusion. And so we can have access to some meta-analysis, and this is the last one published in Adacolumn. We don't have the Spanish trial, but other trial from Japan and the SANS trial. And you can see that when you increase the number of patients in this meta-analysis, you had a somewhat high power comparative trial, and you see that we have a better rate of response and remission in patients treated with Adacolumn, which favors the use of Adacolumn. So the question also that we can have in when we use GMA is how many sessions we have to do to put the patient into remission, or to assess whether or not the patient will respond to the GMA. So we have some trials that compare 5 to 10 sessions of GMA weekly, or in Japanese trial, we have also some studies that try 2 sessions every week, and so we don't seem to have any difference between the group of patients. So you should at least use 5 weekly sessions of GMA to assess whether you will have a response or not to this trial. And we have a European prospective cohort, which was, I think, in Spain, France, and Germany, and we assess the long-term outcome of patients treated with Adacolumn. So patients were put on Adacolumn. All patients, we don't have any placebo group. We had at least 5 weekly sessions of Adacolumn, and we can continue to treat patients through 10 weeks, and the assessments of the primary endpoint was at week 12. And in this cohort, you see that finally the time to steroid-free remission, well, the 40% of patients reach steroid-free remission in this trial, and we have a quite high response in this trial, because more than 40% of patients had a response, and you can see that there was a high early response, and within the month of the beginning of the Adacolumn, you can see a response to the treatment. Actually, in Japan, we usually use as the first line the apheresis, and in Europe, I think we don't use actually as a first line the Adacolumn, but mostly in patients who had intolerance or non-response to other biologic. And in the art trial, you can see that if the patient were or not bio-naive, you don't have any difference between response rates and remission rate, and you can still have a high rate of remission, because about 30% of patients will respond to Adacolumn. So these patients was treated and treated with 10 sessions of GMA, and you can see the scope procedure 10 weeks later, and she had a total mucosal healing, and she was in endoscopic remissions after 10 sessions. So the question is how to continue actually the treatment and the GMA. Should we just stop or just make some maintenance treatment with the GMA? And for this patient, we just decide to start 4 sessions every 4 weeks as a maintenance treatment. So what we have in the current literature, so we have the long-term outcome of the heart trial. So you will see that long-term is not so much long, because it was at 6 months. And however, you can see that after 5 to 10 sessions of Adacolumn, you have somewhat a sustained response across the months, and we still have about 20% of patients in steroid remissions after 6 months and 1 year. However, I just use this recent Japanese trial, because the patients were put on the Adacolumn for 2 months, and they were follow up, and after 10 sessions, they were put on the control group, or they were put on the group of apheresis. So 1 apheresis every other week. And you can see that there were a difference between 2 groups, because we had more relapse in the control group than in the apheresis group. So these patients was put on, as I said, on the GMA every 4 weeks, and she was still on tofacitinib too. However, in June, 4 months later, she relapsed, and you can see the ulceration on the scope. And so we made a re-induction with 5 weekly GMA, and we just shortened the session, so 1 session every other week. And she was put again on remissions. However, in December 2018, she was hospitalized for severe zoster infections, and thus we decided to stop the tofacitinib and continue the GMA alone, and she is still in remission actually. So just to introduce the safety of the GMA, and this is a very safe procedure, and we don't have many contraindications. You can use GMA after cancer in quite old patients. So this is a very safe procedure. And finally, the most frequent side effect we have is just headache during the procedure. and we can see also that in the meta-analysis, because the safety, when we compare to corticosteroid, we had less side effects in the GMA group. So on the long term, I'm quite happy to tell you that we don't have any risk of infection, we don't have any risk of cancer, and this is quite uncommon actually when we discuss biological or immunosuppressants. So we don't have this complication in our mind, and when we discuss with the patients the safety of the procedure and the long-term outcome of GMA, is quite easy to us to have not to talk about cancer, lymphoma, infection, or other things. So just one slide on Crohn's disease, because we have actually few data for Crohn's disease. We all, I think, only have this randomized control trial. This was an American trial, and we have the same pitfalls in these trials and the UC randomized control trial. So you have a loss of patient, loss of follow-up during the trial. And in Crohn's disease, we didn't have in this any difference between the sham procedure and the GMA. However, this is just one trial. I think we should have more data on Crohn's disease to assess the efficacy or not of GMA. So just to conclude, so GMA, I think, is really effective in ulcerative colitis, and here we have about 50% of patients who had a clear response and remissions to GMA. I think you can use the GMA whenever you want, early for patients who had a fear for immunosuppressants, sorry, patients at risk of infection, cancer, and even you use the GMA late is still effective, as the case I just presented to you. So just a sentence a word to conclude. So take care of your patient's arm, because you perhaps will have to use it in the future. So thank you for your attention.